Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. One of the authors of a new textbook about the promise of psychoeducation is here with me to discuss this topic. Dr. Joseph Strayhorn is a clinical assistant professor in Upstate's Department of Psychiatry. He also directs the nonprofit Organization for Psychoeducational Tutoring. Welcome back to The Informed Patient, Dr. Strayhorn.
Thank you. It's a pleasure.
The textbook starts out with some definitions. So for our listeners, what is psychoeducation?
So this is the activity that our book argues is so promising in improving the public mental health of society. Psychoeducation, and it simply means teaching people how to be mentally healthy. An important part of this is how to create mental health-friendly environments for other people. A fundamental assumption behind this is that mental health consists of a bunch of skills that can be taught in the same methods as dancing, tennis, chess, math, reading, writing, driving, any other skill. And what's particularly promising is scalable psychoeducation that can be potentially delivered on a large scale to lots of people.
What are some of the skills that people need in order to be mentally healthy?
We can conceive of mental health as having two big outcomes: being happy ourselves and contributing to the happiness and well-being of other people. There are bunches of skills that maybe we can get into later that help people do these things. Prominent are the skills of fortitude and patience that allow them to hang in there and keep problem solving and not give up during unhappy times. It's easier to be happy and make others happy if the situations the environment is dealing with us are favorable. For example, if we're not immersed in hostile and violent behavior. And also, it's a lot easier if we're blessed with good brain functioning.
So considering the population as a whole, how mentally healthy would you say Americans are?
A mental health researcher's dream would be a totally valid mental health-ometer that could give an instant readout of how mentally healthy people are and how mentally healthy groups are. But given that there is no such measurement device, we do what we can. We look at suicide and homicide rates. We look at epidemiological surveys where people are interviewed or asked to fill out questionnaires about their symptoms or just to rate their happiness. We look at teachers' reports of what children in schools are doing and how often they're doing them. We look at the rates of what's called deaths of despair, which include both suicides and drug and alcohol-related fatalities. And there are other indicators as well. The signal that comes through is that even while there have been big advances that have come through for psychotherapeutic methods and psychopharmacology for treating individual patients, the mental health of the population is not getting better in proportion to these advances, and in important ways is getting worse. For example, a survey of 85,000 college students in 2025 reported that at least a third appeared to have moderate to severe depression, and a third had moderate to severe anxiety. 5% of these 85,000 had made a suicide plan, and 2% had made a suicide attempt. These rates are dramatically higher than they were when the same survey methods were used in 2013. Deaths of despair in 2017, pre-pandemic, were about 3 times higher than they were in the 1950s, when vastly less was known about mental health treatment.
What is the reason for this? It seems like an overall deterioration.
The fact that public mental health seems to be deteriorating while clinical methods are greatly improving, I think is explainable by the fact that there are so many factors in mental health that mental health clinicians have little ability or no ability to influence, like inequality of wealth and social opportunity, degree of corruption in business and government, levels of trust and kindness among people, mechanisms for social connection, prevalence of communication of pro-social values, technological innovations that the culture is just barely beginning to figure out how to handle. The field of psychoeducation research includes the major question: how can we collectively produce mental health friendly environments for the whole society? And this involves understanding three types of influences on mental health.
In your textbook, you talk about biology, learning, and environment. Is one more important than the others, and how connected are they?
They're really inextricably connected with each other, and they cause one another. And it's easy to see how this happens. For example, let's say that you have a biological problem such as lead toxicity or thyrotoxicosis. This can interfere with learning greatly. Let's say that you're in a hostile interpersonal environment. This can create learned habits of not trusting or avoiding connection with other people or trying to exploit them before they exploit you. On the other hand, let's say that you learn good skills of decision-making, self-discipline, and self-care early in life. That would tend to steer you away from addictive substances and thus prevent the biological havoc that these substances can bring about. So just as we can't say whether air, food, or water is most important in survival, we can't say which of these three types of influences is most important. However, in the book, we sort of argue that learned skills and attitudes are a very important entree for public mental health, as it's possible to refine and deliver learning about how to protect our brains and how to create the best environments for people to be in.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Dr. Joseph Strayhorn, a clinical assistant professor in Upstate's Department of Psychiatry, about psychoeducation. Can you briefly talk about the role and effectiveness of psychotropic medications and psychotherapy in helping people develop psychological skills?
The vast majority of mental health labor goes to clinicians who are either prescribing medications or conducting psychotherapy. This is sort of what people think about as the mental health enterprise. Psychoeducation is what we're arguing should at least take its place as a co-equal among psychotropic medications and psychotherapy. And let me talk just for a second about why that is. Regarding psychotropic meds, it's wonderful that we have the ones that we have, and I hope breakthroughs continue being made. Some psychiatric disorders clearly need biological intervention, really qualify as brain illnesses. So I and my co-authors are by no means anti-medication. We're very much pro the appropriate use of medication. But when you look at the most prevalent conditions, anxiety, depression, anger control problems, insomnia, and substance use problems, there are lots of reasons to think that the benefit to risk ratio may be higher with learning-based interventions, particularly if you can begin these before the problem has progressed to a severe state. One of the problems with meds we use to treat these is that the long-term effects may not be as good as the short-term effects. It's hard to find out about the long-term. The gold standard for research is randomized clinical trials, but these typically last about 3 to 6 months. And a survey found that 1 in 8 U.S. adults is taking antidepressants, for example, and a quarter of those had been taking it for 10 years. And I will guarantee that there has never been a randomized trial that has kept two groups getting drug or placebo for 10 years, and I feel sure that there never will be. But there's a problem with the long-term use of psychotropic drugs called oppositional tolerance, or it's also been called homeostatic counterregulation. And in the vernacular, it's getting hooked. This means that the neurons tend to produce changes that are opposite to the ones that drugs produce. This is the same reason why if you abruptly stop opiates or alcohol, there are very unpleasant or even dangerous withdrawal effects. And indeed, there are very unpleasant withdrawal effects for the long-term use of antidepressants and antipsychotics, the serotonin reuptake inhibitors. Loss of effectiveness over the long term is also an issue that's difficult to study. But in general, if the antidepressants, for example, had the capability of bringing about a non-depressed and non-anxious public, it's been given a pretty good chance to demonstrate that for the last few decades. So that's why we think that, okay, psychotropic meds aren't going to cure the world of psychiatric problems. Now let's turn to psychotherapy. I love the fact that the scientific enterprise bears on the question of how do we live well, which is basically what psychotherapy addresses. And psychotherapy is the testing and proving ground where most of the ideas of scalable psychoeducation came from. So the problem we discuss in the book is not so much just psychotherapy work, but the problem of utilization. How many people get enough of it to really learn much? And the answer that we've gotten, and we've looked at massive databases of electronic medical records, and so have other researchers, and the answer seems to be that not nearly enough people get enough psychotherapy to really make a significant impact on public health. A very large fraction of psychotherapy labor goes to a small fraction of the public who can come for a good number of sessions. But for a variety of reasons, the system just isn't built to deliver enough psychotherapy to everyone who can benefit.
So I want to understand the difference between psychotherapy, which I think is usually done one-on-one with the provider, and psychoeducation. You spoke about scalable. So does psychoeducation refer to almost similar to therapy, but for groups?
Right. And I think that psychoeducation can be one-on-one, but when we talk about scalability, we're definitely talking about how do we get it out to lots of people? And how is scalable psychoeducation different from psychotherapy? Well, psychotherapy has kind of been enfolded within the medical system, within the healthcare system, and it's greatly influenced, and some, including myself, would say it's too much controlled by medical insurance. Medical insurance covers psychotherapy only when there's a, quote, medical necessity for it. A diagnosis has to be specified for one identified patient, which means that preventive psychotherapy is not covered. Then the person that delivers it has to undergo years of training, get licensed, get malpractice insurance. Then they have to fill in a medical record for everybody, spend time documenting, have to take on making sure the person isn't dangerous to themselves or others. These are things that can't be done on a population scale. They're just too labor intensive and too much designed for one-to-one work. done by professionals, whereas scalable psychoeducation can be carried out by a much larger workforce. It can include people being their own psychoeducators, simply reading educational books or handouts. The data are pretty good. For example, with depressed people, reading the book Feeling Good by David Burns or reading the book Controlling Your Depression by Peter Lewinson. Psychoeducation can be done and is being done in schools. It has been done by teaching older students to use psychoeducational materials with younger students. I think doing it on a one-to-one basis, but having non-professionals be the ones doing the leadership is a major area for psychoeducation.
So, if we're talking about psychoeducation and the need to teach people skills to stay mentally healthy lifelong, do psychiatrists agree on what those skills are that are important for everyone to know?
The answer to that, regarding whether psychiatrists agree or disagree, for example, with the list that we put forward in the book, is neither of the above. There is very little discussion in the psychiatric or even, I believe, in the clinical psychology community of what are the complete list of skills. What is the diagnostic axis of psychological skills versus that of syndromes? But the question of what is our list of skills that people need to know gets a lot less attention, although it has been attended to by people over the centuries. For example, Ben Franklin made a list of psychological skills, which he called virtues, that he worked at every day and wrote about in the 1700s. And a bit before him, Aristotle made a list of virtues back in the 300s BC. I've listed 16 skills in 16 groups. This has been an interest of mine for decades now. To name just a few of the groups, productivity is applying enough sustained effort to goals to get them accomplished. Joyousness, the skill of generating positive emotion in response to having good luck, having other people do kind things for us, or making good choices ourselves. Having this is obviously a protective factor against depression. Kindness is an important contributor not only to the happiness of others, but also to the happiness of oneself. Research supports the idea that kind people are happier than cruel people. Decision-making, both individual decisions and joint decisions with other people, by definition, help people to achieve more favorable outcomes. Nonviolence and anger control are the skills opposite to impulsive aggression problems. Respectful talk is on the same dimension. Skills of building and maintaining positive relationships are key because they're very highly related to happiness of both oneself and others. Self-discipline is the skill of doing what attains positive goals rather than just doing what feels best at the moment. And courage is the opposite of being impaired by anxiety. And one could go on, but if we just imagine a world in which people were taught these very systematically from a very early age, it's hard to imagine that type of society if the teaching were successful without bringing up the word utopia, which is sometimes a dangerous term.
You're listening to Upstate's HealthLink on Air with your host, Amber Smith. I'm talking with Dr. Joseph Strayhorn, a clinical assistant professor in Upstate's Department of Psychiatry, and our topic is psychoeducation. Let me ask you how psychological skills are tied to reading ability.
There is a strong connection. For example, if you imagine going to school where you're constantly being given tasks involving reading, and you can't make sense out of these little squiggles of letters that you see on pages or screens, you can just imagine what life at school is like, particularly if people around you can make sense out of these things. frustration, anger, embarrassment, shame, aggressive behavior, withdrawal. All of these can be reactions to reading difficulties. At the same time, if you can't pay attention, or if you're so anxious that you're scanning the environment for threats rather than concentrating, or if your impulse control is such that you're bugging your fellow students rather than learning, your behavior impacts your reading skills. So there are causal arrows in both directions. And there has been a great deal of research on this, finding reading causes behavioral and emotional problems, and emotional and behavioral problems cause reading difficulties. And if anybody wants to read a bunch of studies on this, they are summarized in our book.
Let me ask you, if you're talking about scalable psychoeducation, is there room in a scalable model for children that have reading difficulty?
Well, the answer is definitely yes. And paradoxically, one of the things that I've been most interested in has been moving to one-to-one tutoring of reading as a scalable intervention. And how do we get that? We get that by enlisting non-professional people in the enterprise of delivering one-to-one reading tutoring to children. For decades, we've been teaching college students to do one-to-one reading instruction with children. At various other points, I've worked with high school students and even with older grade school students in sitting down with younger grade school students and following directions regarding teaching them to read. And there's lots of things written about this that have produced very glorious outcomes, but it's still not very widely utilized. And of course, the major model of reading instruction is the whole classroom approach.
Do you teach any of the psychological skills through your organization for psychoeducational tutoring work?
Well, this is the whole purpose of it. The list of the 16 skills and groups and the 62 individual psychological skills form the whole outline of the curriculum for OPT, the Organization for Psychoeducational Tutoring. We consider reading as a psychological skill itself, plus it's the avenue whereby kids access the over 20 books that I've written over the last 25 years to be used in this enterprise. There are books that generally talk about what psychological skills are and try to give models of all of them. There are specialized books that deal with self-discipline, anger control, conflict resolution, anxiety reduction, courage skills, friendship building, self-discipline, being a successful student. Part of the idea is you can learn about psychological skills by reading about them at the same time that a child is practicing their reading decoding and their reading comprehension. So they're practicing two of the most important psych skills that exist, along with the skill of being cooperative, which is a third.
And is the website optskills.org still the best way for people to learn more about that?
Yeah, and on the website, there's the whole bunch of books that we use, that tutors use in what we call alternate reading with children. A lot of these are written in a quote programmed format where there's like a couple hundred words and then a little question. Was what you just read this or that? And this gives the child the chance to respond. I think it's this. And at least 80% of the time, the tutor gets to say, you got it, or I totally agree. And if it's too hard for the child to get 80% of the time, we go down to easier stuff. There are also books having to do with psychological skills exercises. And this means things that people can do together to practice psychologically skillful maneuvers. For example, one of those is the celebrations exercise, where the tutor says, Let's think of things that we're glad we've done. I'll go first and tell you, and let's see, which psychological skills do we think that's an example of? Okay, your turn. What's something you're glad you've done? And if they can do this every day, they're devoting their attention to practicing the skills that make up mental health and celebrating each little practice that they do.
Very interesting. Dr. Strayhorn, I want to thank you for making time to tell us about psychoeducation.
It's been a real pleasure, and I salute the listeners or the readers who wish to be informed patients. They deserve to celebrate their productivity.
My guest has been Dr. Joseph Strayhorn, a clinical assistant professor in Upstate's Department of Psychiatry. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/inform. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.